how are you? Katy Lee's here, Principal 340B Compliance Advisor with Virtue 340B. I'm super glad to be back. I apologize. I guess we took a little bit of a summer hiatus. Aside from trying to enjoy the summer, it's been really crazy in the 340B space, which I probably don't need to tell most of you. So it's been hard to find the time to make these videos, but I really like doing it. I hope you've been enjoying them as well. Love hearing the feedback. I've been hearing a lot of feedback. Please keep it coming. And I thought today I'd just touch on some of the hot topics that I've been encountering, that I've been spending my time on. And again, if you ever have anything that you would like to hear my perspective on, a question you think I might have an answer to, please put it in the comments, post it on LinkedIn, send it to me, however you would like to do that. However you have the means to reach me, I would love to hear from you. Okay, so first I was going to touch on some topics that I actually covered in a recent blog. If you didn't see it, I hope that you will check it out. I posted it on LinkedIn. It's also primarily posted on our Virtue 340B website. So the blog was based on my reflections from attending the Medicaid Rebate Summit. Full disclosure, I did not attend the full conference, so certainly don't want to misrepresent there. I had the opportunity to participate in actually a pre-conference event. It was the night before the conference started, and then I stayed for part of the conference to attend some of the sessions. The pre-conference event that I was a part of was kind of just a collaborative roundtable session. It was very open. It was, I think, like 2.5 or 3 hours where myself and some other stakeholders had been asked to kind of, I don't know, we weren't panelists, but facilitators of the discussion to talk about mostly good faith inquiries, all things around that. Some of the other stakeholders, it was myself, another person from a covered entity, 2 people that represent the Medicaid side, and then 2 people representing the manufacturer stakeholder group. So I thought it was a really great session. I hope that they, bring it back and that it just continues to expand, because I think that that's the type of setting where we're going to get a lot of value, where we can really just talk to each other, learn each other's perspectives, pain points, where we can work together to do better, maybe where we're failing today. So I just really thought that was great. So a lot of this takeaway was from that. But also it was just kind of themes that I picked up in other sessions that I attended too. So the first thing, it was kind of a little bit of a revelation or something that I learned, and maybe I should know this based on conversations that I've had for years. I feel like I somewhat should have known this, but sometimes I'm a little dense and I just need to be specifically told something to truly know, how it works. But one of the conversations, or it came up multiple times actually in during the session, was that the primary thing that manufacturers are relying on to dispute rebates with state Medicaid agencies is the Medicaid exclusion file. Now we know just the visibility is not there for them the way we know of what, we're carving in and we're carving out. But I was just, again, this kind of blew my mind, and it probably shouldn't have. But the fact that, I don't know how many, but it sounds like maybe most manufacturers are just relying on if a covered entity is in the Medicaid exclusion file saying that they carve in. So this is when you register for HRSA, you say that you bill Medicaid fee for service when you're filling a prescription or administering a drug. You will utilize 340B inventory and bill it to Medicaid fee for service. So that's carving in. So entities that are reflected on the Medicaid exclusion file or the HRSA database as carving in, they are taking the assumption from that there should not be rebates claimed by state Medicaid agencies for those entities. And that's just not true. I mean, I understand why the Medicaid exclusion file exists. It certainly has served its purpose. It still somewhat serves its purpose, but it's pretty outdated at this point. It's not the primary source for most states. I tried to do some research after this to figure out how many states just solely rely on the Medicaid exclusion file for preventing duplicate discounts, and it was hard to figure out because I think we all know there's not one great source for, how states are managing the intersection of 340B and Medicaid. Problem one. But from what I could tell, I think there's around a dozen states that are relying on a Medicaid exclusion file to prevent duplicate discounts. So in those states, this should be a reliable source for drug manufacturers to identify potential duplicate discounts when they're getting rebate claims from state Medicaid agencies. For all those other states, it's really not, because if a covered entity says they're carving in, but their state uses claim level identifiers, then that's how they are telling the state when they use 340B drug. And so, there's an option there, and operationally there's really a need. It's not even an option, it's a necessity to be able to carve in and carve out prescriptions or drug claims based on that patient's eligibility, how that business is set up, just what makes the most sense operationally. And from a compliance standpoint, you're identifying that a prescription is 340B eligible or not being dispensed using 340B drug by using those claim level identifiers. Again, that Medicaid exclusion file still needs to be accurate for all of those entities across all of those states, but it's not really going to be a good indication on whether or not covered entities are using 340B drugs for their prescriptions. And it's going to be very unlikely that in those states, covered entities are 100% carving in or 100% carving out, because it's just not that easy. If you have a hospital-owned pharmacy where you carve in, you most likely will be using 340B drug when you bill Medicaid, if that's the decision you've made, if that's the best business decision for you. But there's also many situations where a patient has brought you, they are your patient, you're filling their prescription that came from your organization, but maybe they also see a specialist or a dentist or someone else, their OBGYN that's outside of your network. They still want to fill that prescription with you because that's the best scenario for their care. They should be using one pharmacy for all of their prescriptions, but that one prescription doesn't qualify for 340B. So that one you're not using 340B drug, but all of their other prescriptions you are. Or maybe you don't necessarily want to carve in for Medicaid, but you kind of have to for some drugs because the reimbursement is just so much lower if you have to use wholesale acquisition cost to dispense those prescriptions. So it just makes better business sense to carve in those prescriptions so that you make, let's say, a $10 dispensing fee, and you get reimbursed the acquisition cost plus that $10 dispensing fee. So you carve in that, but largely you're going to carve out prescriptions that get billed to Medicaid. So I'm rambling a little bit. I hope all that made sense. But basically my message is it's not simple. It's not simple, the carve in, carve out decision. It's certainly not simple and not a successful way to identify 340B prescriptions, or more so if that a duplicate discount occurred just by looking at the Medicaid exclusion file. So that just really troubled me because it just highlighted for me that the system is just broken. That, the argument has been for a long time that duplicate discounts are just, out of control, and that there's fraud and there's abuse in the program. And, I guess I thought that was a little bit made up in a narrative that, was just being sold to bring down the 340B program, and that might be the case in some situations. But this really highlighted for me that the system is broken. none of us have all of the right information to assess this. So, you know, if all of the drug manufacturers are being told to rely on the Medicaid exclusion file, and I understand this is basically one of the only tools that they have to identify, you know, potential 340B transactions, to use that information to dispute rebates because they think they're duplicate discounts. Now, I understand, but again, that's just not an adequate tool, because that's gonna result in so many false positives. You know, I participate in many good faith inquiries where I'm asked to review spreadsheets of claims that rebates were, you know, state Medicaid programs have asked us to pay rebates on these, but your covered entity carves in. And we want to know, you know, were these prescriptions 340B, because then we shouldn't be paying rebates. And no, the rebates largely, at least that I'm associated with, or that I, you know, participate in these good faith inquiries, that they're non-340B transactions that the rebates are being requested for. And that's just, I have to assume, as a covered entity, you know, they are brought into that conversation probably a small percentage of the time. You know, what I heard in these conversations when I attended the MDRP summit is that this is a constant flow of back and forth between manufacturers and state Medicaid agencies. Again, the manufacturer disputing all of the rebates based on the Medicaid exclusion file and the state's response. And I guess I don't understand how they ever get resolved, because neither of the parties have all the answers. The covered entities have the answers. So again, it's just, it upsets me that it's so broken. That, you know, what's the solution? No one is necessarily doing the wrong thing. I think everyone is really trying to do the best they can, but there's not any place where we can all come together and share the information that would be most relevant to resolve this issue. So, you know, I'll just go back to, if we could ever get to a world of a clearinghouse model where covered entities are sharing this information, it's merged with the information from the state Medicaid agencies and, you know, in our future state, other CMS data for Medicare patients, you know, I don't know how else we can get to a place where this flow of information and resolution of these conflicts can really be handled efficiently. You know, I'm not, it doesn't seem like we're necessarily moving in that direction, but I'm still going to keep beating that drum. We need to do better. We need a better system. We need to communicate and share information in a better way. You know, along those lines, another big topic in that room was we need to collaborate. We need to talk to each other when these disputes are happening. Again, the covered entity needs to be a part of it. And I think that we've gotten to a place where that's become very challenging, because it's a very contentious world that we live in. You know, the stakeholders in the 340B program are far from seeing eye to eye, and we're at a point where it's, you know, basically an impasse. Well, we need to find a way to work together. You know, I think about it at the local level. So not even trying to solve big problems, but just to solve like the local little problems of, we have these transactions that, you know, state Medicaid is asking the manufacturer to pay the rebate, and the manufacturer thinks that they might be 340B. Those need to come to the covered entity. And when they do come to the covered entity, because again, I think that a lot of the time they don't, but some of the time they do, whether it be through a third party or directly from the state or the manufacturer, we need to be open to that in the covered entity community. We need to be open to collaboration, because that's the only way that we can, you know, get these things resolved. So that was really a huge message, and that everyone, I think nearly everyone at least, in that room at the pre-conference roundtable session that I was a part of, we really just shared in, we need to find a way to work together. We need to communicate. We need to understand each other's perspective in the pain points that get in the way of us doing our job efficiently. So I guess part of what I'm here to share today, I apologize if I rambled a bit about the Medicaid exclusion file, because that is frustrating. But I think a more important message is that we all just really need to communicate as best we can. I understand that sometimes these good faith inquiries have gotten to a point where it's difficult to have like a fluid back and forth, but as much as we can, we really, really need to do that. I guess jumping around a little bit, one other topic that I saw come up in a different session was talking about, the profits of the 340B program. And, yes, there is a difference, obviously, between the 340B price and the non-340B price. There is also a difference between what a covered entity might be reimbursed for a drug and what they pay for the drug at 340B. I mean, that is the point of the program, is that difference is meant to be applied in the covered entity to use that for meaningful purposes within the entity, within the community, to expand services, to give out free drug, to, just maybe just support other services, programs, anything that is going to benefit the patients ultimately. Like, yes, this is not always a one-to-one. The hospital or the covered entity gets a discount and that discount makes it to the patient. But ultimately, the benefit is making it to the patient. And that's the point. So that benefit exists for a reason. But I will say, I guess my main comment on that is that, the difference between the wholesale acquisition cost and the 340B cost does not necessarily equate to profit. I don't ever really like to use profit in these worlds because we are not-for-profit organizations. So it's not being used or considered profit. But there is a margin oftentimes, but that margin does not necessarily equal that wholesale acquisition cost, WAC, minus 340B, because reimbursement is pretty weak these days. If we're talking about being reimbursed for a drug claim or being reimbursed for a prescription, oftentimes that reimbursement is less than what that wholesale acquisition cost is. So, it's the profit, or we'll say the margin on that transaction, is between the 340B cost and what that covered entity gets reimbursed. If you check out my most recent blog with reflections from the MDRP Summit, I included a couple examples. Not by drug name, but there are real drugs behind that. Those are real, true life examples. So please check that out. We really need that to be incorporated in these conversations. We need that to be understood for us to effectively be, having these conversations and maybe, making an impact, making a difference in managing these programmatic changes better, because that's an important part of the conversation. And the last thing that I wanted to talk about, something this week, this is not necessarily related to my MDRP experience, but something that has been a big focus of mine this week, it's come up in a few different conversations with different stakeholder groups, is purchasing data needed for the HRSA's rebate pilot policy? And also in the same sense, is if we do reach that, what I would consider ideal state of a clearinghouse being at the core of, the program, 340B program management, it's the same thing. Is purchasing data truly needed as a key element to, make this all work effectively? Which the point of all of this, I believe, my understanding is the point of the rebate program, and if we, are able to execute a clearinghouse someday, is to prevent duplicate discounts. And I just really do not feel that purchasing data is necessary for that. And on the contrary, I feel that it would just complicate and lead to mistakes in management and understanding of the data. So I just really, really, really hope that, HRSA sees this and doesn't approve that the purchasing data elements to be part of the requirements in the rebate policy. Just some of my thoughts on why, because obviously I need to explain and defend my position. So first of all, the timing. So I think that, when a transaction is deemed 340B eligible, to simplify, let's talk about a prescription. So when you adjudicate a prescription, it is going to be billed, we'll say billed to Medicaid. So that is when a duplicate discount would start, if a duplicate discount is going to happen, because you are telling Medicaid, let's say you plan on using 340B drug, you have a prescription, it's deemed 340B eligible, it's billed to Medicaid. You might accumulate that prescription and purchase it in 30 days, or you might purchase it today, next week, whenever. You have accumulated it and you will be purchasing that prescription at 340B pricing, but it's, depends on many factors when that will happen. But what we know is that if you do not identify that transaction properly as 340B to Medicaid at the point of adjudication, that ultimately a duplicate discount is going to occur, because they are then going to request a rebate from the manufacturer. So from the timing of that, that's where a duplicate that's why the transaction actually is the most important thing, of identifying that 340B transaction, which is going to correspond with the rebate data. So there's that. Also, just from a reporting sense, if you don't compile your data at that point of whatever you select. So if it's the point of adjudication, if it's the point that your 340 or your third-party vendor determines that transaction's 340B, if it's when it's dispensed, like at some consistent and standard point, you are going to determine that as a 340B transaction. And that's when you would report it to, whether it be for the rebate or be for, this future potential clearinghouse model, you would report it at that time. Now, if it was determined that you needed to wait until that purchase happened, again, that's not a consistent timeline. It might be tomorrow. It might be next week. It might be in 30 days. You're not going to be able to report that out consistently. It's not going to correspond with the timing of the rebate data, the billing of the prescription. It's just going to be messy and unreliable. It's also, you're just not going to be able to, there's not many settings where the purchase of the drug is cleanly reported with the transaction. Like, that does exist. Again, a lot of times that reconciliation and the tying of those transactions happen downstream, because that's when the purchase happens. So asking for the purchase data to be tied to this activity, whether it be by the covered entity before they submit the data, or by a vendor that does it after you submit the two separately, that's just not going to be a clean, accurate reflection of what happened. That's manipulating and making assumptions of what purchases go with what transactions. So again, I just think that would be very messy and it would be very unreliable. Again, we'll go back to like the real duplicate discount prevention is using that transaction, like the prescription for, the prescription example. That's what is going to start the process of a potential duplicate discount. I mean, yes, if a purchase never occurs, so if for some reason you accumulate the drug and you never buy it at 340B, then yes, that duplicate discount, like that full loop didn't happen and it wasn't ultimately a duplicate discount. But I think that that's a different problem to solve downstream, and not even a problem, just, if you are working through a duplicate discount inquiry, that's something that, needs to be a part of the process, is validating if a purchase occurred. But I think that is a lesser concern. I think once you identify something as 340B, the assumption is made that there will be a purchase that corresponds with that. So I just really stand that transactional data is what is key in identifying and preventing duplicate discounts. The next reason is I read that at least one of the manufacturers in their responses to HRSA was saying that this information was needed to determine what the rebate should be, to see what the covered entity paid for the drug. And I guess my response to that is, like, why do they need to know what was paid? I think it's going to be whack. And maybe there would be some sort of wholesaler discount if there is an agreement with the wholesaler that there's a discount, a cost of goods discount or something like that. I mean, I don't think that that's relevant in the transaction. I think that we need standard rebate calculations, just out of, that's the reasonable, fair thing to do, but also for transparency and for consistency. there needs to be a standard rebate calculation of WAC minus the 340B ceiling price, and that's what everyone should expect as their rebate. I think that that's not a valid argument, that that's why purchasing data is needed, and that would be acceptable for rebates to be calculated based on what that purchasing data said. So I hope that is understood as HRSA is evaluating this. I know that another concern for manufacturers is this transitional period. So, if we do go live with the rebates on January 1st, then there will be a time period where covered entities need to ensure that the data that they're submitting is for transactions that didn't already result in a 340B purchase prior to that period. And again, that will be a challenge, but I don't think that uploading purchasing data is going to, make that any easier, or if anyone thinks that covered entities are going to try to cheat the system by, uploading data that they know that they already got a 340B discount on. I don't think that providing purchasing data is going to lessen that burden or the risk of, maybe some sort of fraudulent transactions. Because if someone's going to do that, they're probably going to fudge the purchasing data that's, included anyway. So I don't understand that argument either. I will stand by professional integrity. I mean, there are a lot of expectations for covered entities in regards to healthcare compliance, and this is just another one. So I think that there should be a standard expectation that everyone is, conducting themselves with professional integrity, just like, when you're billing CMS or you're doing anything. That is a pretty standard expectation. So while, like I said, it will be tricky, and covered entities will have to be careful that when they are uploading data, especially, soon after the pilot goes into place, you need to make sure that if there's data from a setting that maybe has a physical 340B inventory that was already on the shelf when they administered that drug, that shouldn't be included. But I think most settings that maintain a virtual inventory, and the transaction that happens after January 1st or even slightly before January 1st, would result in a future purchase. So that is valid to be included in that rebate data. And I just really think, as a general statement, that it would just complicate things so much. Again, I mean, I've already said this, so I'm repeating myself, but having the purchasing data included and trying to reconcile that when it just isn't serving a purpose, and it's just going to complicate things and, lead to manipulation and assumptions that will just make the data much more difficult to manage and just less reliable. I just really think that it adds way more complexity, and it doesn't have added value. And not only does it not add value, I think it reduces the value and the reliability of the data. So like I said, that's a conversation I've been having quite a bit lately. I hope that it makes sense. I'm interested to hear if anyone has any other thoughts, maybe if you disagree, if you have additional reasons to support that argument, I would love to hear it. I think that we all need to be talking about this because this is really important right now. I think that we've all succumbed to the fact that January 1st, rebates are most likely going to be a reality. And this is one area that maybe we can make it a little bit more manageable for ourselves, to not, have it be overcomplicated by needing to also include purchasing data. So I appreciate everyone listening today. I hope that wasn't just all rambling. I obviously feel very passionate about all of this. I spend a lot of time on it, as I'm sure most people that are listening do. I hope that you enjoyed this and you found it helpful, and I would love to hear from you in the future. Have a great day. Bye.